Hi everyone, it's Dr. Paul Sunga from the Biology Department of Langar College. This talk is going to review and provide updates about the COVID-19 epidemic and the virus that causes it, the SARS-CoV-2 virus. This talk is oriented and meant for my students in pathophysiology, Biology 3192, as well as the other students in the other two sections of pathophysiology. But it will be made available on YouTube, on my YouTube channel, to other people who might be able to use it. So, just to start off, we can look at a beautiful picture. It's a bit of a haunting image. It's provided by the National Institute of Allergy and Infectious Diseases in the United States, and it shows the virus infecting cultured cells. So another beautiful image shown here, which is a scanning electron micrograph showing the virus with its spike protein, which is the target of most of the vaccines that are being developed right now. Actually, it's got the main antigens. I'll talk about this later a bit more, but this is the primary target for vaccines antigenically. The outline today is I'm going to take a few epidemiological perspectives. It's kind of just a few points. We'll look at global Canadian and BC perspectives, and I also want to talk about a few technical issues there for the students. Then we'll get into the pathophysiology and some clinical things, including interventions and drugs, and we'll also look at immunity and vaccines and the latest area of concern, which is the development of variant strains that are popping up in different parts of the world. So just straight to the epidemiology. This is just a sub-outline, I guess. It's showing the global, we'll talk about the global Canadian and BC trends, risk factors in high-risk populations. And then the technical parts that I was mentioning are about R0 and infectivity, which is being talked about and used by a lot of policymakers right now, so we want to know about what that is and what it implies, and about fatality ratios. So just taking a global picture for a moment. This is, global distribution of COVID-19. Hey, what's wrong with this map? It's all distorted because it is a picture in which the various countries and regions, the various countries are shown with color schemes, but regions, I should say, are shown by color schemes. But what it is showing is the relative proportion of cases which are occurring. And this shows, we're talking about right now, as of today, January 15th, we're looking at 94 million in total worldwide. Something like 2 million, just over 2 million deaths as of today, by the way. Something like 750,000 cases being added per day, and something around 15,000 deaths occurring per day. So these numbers have really grown massively over the last few months, and we're looking at quite a different stage of the pandemic. But if you look at this map, you can see, China disproportionately, and the United States disproportionately taking up most of the space of the land masses, and that's shows you where most of the cases are anyways. But Europe is shown very, very large. Africa is kind of shrimpy. Of course, there's a few issues around this, especially with respect to the efficiency of penetration of the population of diagnosis and screening. And secondly, when we look at the case reporting and how well it makes its way through to the official channels, that's another issue. Depending on which country and what kind of governance is going on there, we've got quite different scenarios, and I'll mention these in a. This is a similar map. It's showing instead deaths, and as I said, we're talking about something like 15,000 deaths per day right now, and so far the total is just over 2 million. By the time you look at this, it'll be higher, of course. So large, it's a little different. If you look at the two maps, you notice just in North America, Mexico occupying a much bigger proportion of deaths than cases. And similarly, when you look at countries in South America, is somewhat different. But anyways, so this gives you an idea where the concentration of cases are, where the concentration of deaths are. We've got currently the global picture is as a surge, but just to look at some of the technical issues that might inform this kind of data, what I was saying is that case detection rate varies widely across the world, especially between areas that are highly industrialized and those that are less developed and have large rural populations, as in Africa and large parts of South Asia, India mainly. So you have issues of case detection rate. What that case detection rate encompasses is, of course, how much testing is going on, how efficient the testing is, and then also what is the reporting capacity down the line. So one of the things we know is that reported cases from surveys that have been done diverge from the actual cases that are occurring. So this is one of the issues that can really confound our idea of, for example, how deadly a virus is, or how widespread the pandemic is, of course. One of the things that we can look at with respect to mortality, though, is that one method that's been employed in quite a number of studies by now is to consider excess deaths compared to the deaths that are actually reported as being COVID-19 deaths. What we mean by excess deaths is if you were to go back to the previous year data, or a couple of years back perhaps, and look at the same time period and see what the death rate is, you can come up with, where you take a few years, you can come up with an expectation of what the death rate should be during the pandemic, and then look at what it actually is. So if you have a difference between the excess produced by COVID-19 and the actual excess number, you can assume that something is going on, either directly or indirectly, to do with the virus. And those kind of things you would expect to be not only COVID-19 infections, but also deaths that occur indirectly by people, for example, not seeking out health care and dying of other causes because they haven't wanted to go to clinics or hospitals. So if you look at one of the studies by Contest et al. That appeared fairly recently in Nature, they found that something like between 7 and 38% divergence between expected excess deaths and then those reported by COVID-19, meaning that there's an underreporting. This is basically it. And in other studies, including in some states in the U.S., we expect that the difference between reported COVID-19 deaths and those estimated from this excess death calculation can be up to 50%. So it's much more widespread, and there are more deaths occurring than in most places than are actually reported in the numbers. If we just go to Canada right now and look at the latest data, actually it just came out today, the most recent report from the Public Health Agency of Canada, which I'll hesitantly refer to as PHAC. But that, by the way, that agency is, of course, was set up as a result of the first SARS epidemic that occurred in 2003, so just as an FYI there. But they are our central agency, which is collating this data and reporting on it as well. So, yeah, the major message here is when we consider the latest surge in comparison to what everyone was obsessed with back in the spring, which was the first surge, we are into a much different scale of incidence now, and also death rate that's going on. So these are based on, the red line is 7-day moving average, so you're taking the average over the last 7 days at whatever point you're at, and the yellow lines represent the dailies. So this latest run-up was anticipated as a result of the Christmas holidays. Where it's going now, it's a bit hard to tell, and I would say there's differences between the different jurisdictions in Canada as to what happens next. Because when you look at this is again latest data from Public Health Agency of Canada, if you look at this province-wide, the darker colors being more cases per capita. Oh, sorry, this is raw numbers. We're looking at 54,000 cases, and we're looking at total counts of cases. So you'd expect higher case number, of course, in the more populous provinces, Ontario and Quebec, British Columbia, and less than the others. But if you look at this as a matter of cases per 100,000, this is more relevant, really. If you look at how intensely the epidemic is affecting people with respect to cases, you find that it's quite a different map. You've got areas that are relatively low numbers now, that are even outside of cities, where you have a high proportion of the population which is being affected. And so it's basically become much more widespread. This one of the messages is that it really began in metropolitan areas and is distributed out into the rural areas by now. So hotspots were initially cities, recent infections have been rural, and very high incidence, by the way, in Indigenous lands. Very hard to get a fix on it because data has been sketchy, but we know that it's extremely high, and there's also a very significant death rate, at least per capita death rate, in all the Indigenous areas. So one of the things that's noticeable when you look at these maps, though, is if you look at case numbers, of course, is proportional to population, but if you look at per capita, where concentrations occur of high infection rate per capita, there are differences that reflect provincial differences in governance decisions, such as some of the things that have been quite highlighted, I suppose, with respect to political issues and governance issues are there's a sector of the population which is objects quite strenuously to any infringement on personal liberties, or libertarians, of course. Some provinces are chafe at having federal government imposed guidelines. Some people don't enjoy public health, in which you have communal and social action, which is the something where you have to give up some of your rights, and you're supposed to contribute to community health by taking responsibility. Again, this is political stuff which plays out in Canada even more strongly in the United States, and it's been an utter disaster there with respect to managing all these things, to be frank. But if you look at the governments of Alberta, Ontario, and Manitoba, you've demonstrably weaker policy responses that accounts in large part, at least hypothetically, and I think the data already bears it out, with more infections and deaths per capita compared to other jurisdictions where you have more proactive public health centered policies, British Columbia, Atlantic Canada particularly. So looking at this, aside from political jurisdictions, if you look at the data in Canada with respect to age cohorts, you see that different colors are shown below in the legend. That blue is the 80 plus, this is incidence, so cases per population at any one moment. If you look at the older age cohort, you see a quite high surge going on here. Notice that the second most infected cohort is the 20 to 39 year age group, and then you have the other ones below that. So this is food for thought with respect to vaccination strategies. They are taking the approach of vaccinating the elder cohort first to address the high death rate, because about, I think about 2/3 of deaths are occurring in this group, of course, but 20 to 39-year-olds, very high rates of infected compared to, they're the second most infected group. So, yeah, British Columbia, large surge since November. There's been a little bit of a recent reversal. Things have started to calm down a bit here, but there's a few things that come out of the data locally in BC. About 93% of the cases are mild and asymptomatic, which there's two things there. One is that's a little higher than other places. You've got a lot of mild cases, but the other part of it, of course, is we're going to have to pay attention, especially to asymptomatic people, because of asymptomatic spread, because asymptomatic people won't necessarily get tested, but they transmit well. So most cases in the metropolitan health districts, most cases are in the metropolitan health districts, which is Fraser, which is Surrey, the Valley, and also the coastal region here, which is Richmond, Vancouver, and Sunshine Coast and the North Shore. So a lot of concentration in elder care facilities, long-term care facilities, as they're called. Food processing facilities have been other hotspots. And among younger people, it's the 20 to 29-year-old cohort, which is showing very persistent surges, I would say, especially in that group compared to children or even people in the up to 70s, other than that group. So what's the reason for that? It's anybody's guess, but certainly what we see is younger people not necessarily being able to maintain their social distancing and public health guidance over a very long period of time. Just very difficult for them. 2/3 of deaths, I said, have been in long-term care facilities, and that, of course, is among the older group. These are all from the BC Centre for Disease Control. Other things to look at here is this shows the different health regions in British Columbia. We've got these health jurisdictions, which are broken up, as I said, by regions. So Fraser, Vancouver Coastal Health take up most of the cases, and then you've got a few others as well. And this also reflects the stabilization of the recent surge that has happened. So, interestingly, just comparing hospital census, death rate, and cases, we'll see that our hospital census means how many people are registered in the hospital with COVID-19, and that actually, I should just correct myself here. Hospital census means the number of people that are inpatients in a hospital, period. So this shows, a bit of a surge, but I'm going to show you that we're still quite below capacity for hospitalization in British Columbia. That's been managed quite well so far, and also shows, some effect of different levels of restrictions that have been brought into place in British Columbia. We're still not under so-called lockdown, as has happened in a number of the other places, but the guidelines for gatherings, and now they have, and with the new restrictions that were implemented in November, there's a ban on gatherings. It's enforced. There's been fines given out for people who have defied it with parties and those kind of things, which is had, presumably, it started off to having some almost immediate effect, perhaps, but it's difficult to say how different things would have been if those regulations, restrictions had not been brought into place. So one of the things we can look at with interest is what are the sources of infections, where that's known with contact tracing. This shows a few different classes of basically unknown exposures is one thing where you can't contact trace back. Whether it's local versus outside exposure from international, this is one of the issues that's always sort of a hot button issue for populations. They are concerned that people are bringing the infections in from outside. And then, there's, as the pandemic goes on, it becomes more and more difficult to assess this information and really find out. But note here just a couple things. If you look at international travel, it was initially an issue, but now if you look at it, it's pretty much disappeared. Of course, there's so many international restrictions from places and to places that we have much less travel, and then there's been a lot of media attention placed on people who have been traveling anyways. But certainly most of the cases are local spread, so this is what's going on, is community spread. Once you get into this high numbers and community spread, it becomes much more difficult to do things like contact tracing, of course. So if you compare British Columbia in terms of hospitalization rate, as I said, British Columbia is this line right here, which is right at the bottom as of January 12th. So management of the number of cases in a hospital per 100,000 has been very good, with a lot of mild cases, a lot of asymptomatic cases, and then the public health regulations, at least in this measure, seem to have worked to flatten the curve out quite well. So it's compared to other provinces in Canada, and you can see at the very top, unbelievably, Manitoba, which has very, very high hospitalization rates, and also Alberta. Yep. If you compare British Columbia with international jurisdictions, with other countries, Sweden, USA, UK, Germany, and what we're looking at is cases per 1 million, again, cases per capita. This is again based on 7-day moving averages up to January. You can see South Korea and India at the bottom. India with its huge population. South Korea has been very, very active in controlling and with public health measures right from the beginning. And then you have other countries, Sweden and USA being up at the top. The United States with entirely chaotic or lack of leadership in many places, and then a lot of contradictory regulations in different places as well. Sweden, which really tried to let the cat out of the bag and allow people to become infected with the idea that initially it was going to lead to herd immunity. That has not worked out. And then UK, Germany, these are large populations that notice the sharp incline in the UK, and we'll talk about that in a few minutes. So just a couple of, this is the technical bit that I was talking about. I wanted to make sure that you as students or interested people have a look at some of these statistical numbers that can reflect important aspects of this pandemic. Hazard ratios are a way of quantifying the hazard rate of death, the risk of death for different subpopulations. So this is it's a rate of death, a risk of death over time intervals. So if you compare, you have to look at what it is compared with in terms of this ratio. I try to stipulate it in these indications of risk factors in subpopulations. So for example, I was mentioning about age cohorts. If you look at the risk of dying for over 80s, okay, this is 80s, means over 80s, it's 38.29, which means that the hazard ratio is 38.29. It means that the risk of dying for that cohort is 38.29 times that of the comparable group, which is arbitrarily set at the risk of the 50 to 59-year-old population dying. So a member of this population dying. So this, you could set, unity or 1 at any age group, but it's set arbitrarily at the 50 to 59 group. So, if you look at, say, just another sort of factoid that I put in here, nursing home and long-term care facilities, patients, again, they're in the U.S., this is a reference I've mentioned here, that's about 38 to 60% of the deaths, and then I mentioned 2/3 in British Columbia. In other places, in many places, it's where they have long-term care facilities anyways, is likewise as high. If you compare males to females, almost double the hazard ratio, 1.78. If a patient has a comorbidity, for example, if they are obese, so this would be what you're comparing with here is people with a BMI of over 40 compared to people with a BMI which is considered in the normal range, okay? They are, technically speaking, obese, and 2.66, times as much a risk factor for hypertension, and we gave a lot of attention to hypertension as a factor that puts people at risk for death. But it's relatively, now it's been found out to be, over time, relatively a small effect. Respiratory disease, quite high, and you can look at these other things as well. But if you look at something that is more dramatic in terms of a risk factor, stroke or dementia, 2.5 times plus, and organ recipient 6 times the risk, and immunosuppressed people, of course, and all of this makes sense. Neurological, this is a little bit, this is kind of a fascinating comorbidity. Neurological disease, about 3 times the risk. So you can look at other factors, not just comorbidities. We've got male sex, we've got age, comorbidities. This is sampling of the most important ones, I suppose. Ethnicity, so-called ethnicity, so people from identifiable ethnic backgrounds who are compared to white people, as if white people don't have an ethnic background, but whatever. So comparing South Asians, Black, and Indigenous, I don't have the actual number for Indigenous. I'm sure there are estimations out there, but it's been difficult, and we know it's very high for Canadian Indigenous people, that they're at a higher risk for death. What are the reasons that these populations have been found to be more at risk for COVID death compared to white people? We have to look at what the countries are where these studies are done. So they're done, there's quite a number in the UK and in the US and also in Canada. They're not likely to be biological factors, but more social factors, and also the healthcare factors, whether or not they are treated in the same way in hospitals and clinics as their white counterparts. These are all issues that have been suggested as possibilities. So we also know that people who are lower on the socioeconomic hierarchy end up being more at risk, especially people who are busy doing essential jobs they are in wage jobs where they don't have support if they stop working because of the epidemic. So these are from the Williamson paper, by the way, is found in Nature. This is UK data, strictly speaking, and all of these are from the Williamson paper. So this just shows the age and hazard ratio relationship. Not surprising. All right. So again, with technical issues, and there's a reason that I want to talk about these things, you'll see, but the first issue to talk about is the reproductive rate. It's called the basic reproductive rate, or also known as the R0. I'm sure you've all heard of it by now. But there's a few things I want to make sure you understand about this. What R0 represents is a calculation of the growth of the epidemic in a population, and it ends up being different for different infectious agents. Of course, some infectious agents transmit very, very easily from one person to many people, and others not so easily. So it reflects some issues that are intrinsic to the infectious agent, but it also is influenced by a lot of other different factors. So the basic thing is to know that if the R0 is under 1, which means that on average an infected person infects less than one person, then the pandemic will basically peter out. And of course, if it's greater than 1, it means that it's going to grow, and the more the higher number, the faster the rate of transmission in the population, and the faster the pandemic is going to spread in the population. So here's the key things to realize about it, aside from looking at the relationship with herd immunity in this calculation. Don't worry about it too much. The key thing is that for any epidemic, for any infection in a population, the R naught is a very dynamic number. It changes. It depends on a whole bunch of different things, including not only the infectivity of the particular agent, in this case the virus, but also because of the environmental and because of the interventions, the kinds of defenses mounted by the population. All these factors are changing all the time, and it's going to be a dynamic number. This last point here, though, and the simple calculation that's shown here, it's about herd immunity. That there's a relationship between transmission efficiency and herd immunity. So you can use this calculation to determine what the proportion of the population would need to be, say, vaccinated in order for the pandemic to basically recede. And that, as I said, it's going to give you an estimate based upon assumptions about the behavior of the virus. So conceptually, there's really 3 major sets of factors known as the epidemiological triad, which give you this quantitation of the vector-host relationship in a pandemic. The first one being the agent, in this case the virus. As I said, it's viral biology, such as genomic features, i.e. new strains that are popping up have a different R naught than the old strain, and with each new strain that pops up, there's concern about whether if the agent is more transmitted, that the R naught is higher intrinsically. The second thing is the susceptibility of the host population. So, for example, the immune and defense status of the population, which can include things such as nutritional status, the age of the population, all kinds of characteristics which affect their ability to mount immunity. And then environmental factors. Now, these can include all kinds of things, including social factors such as public health interventions. I see I left this, I was going to write something and then something interrupted me, no doubt. But anyways, the key thing is this means that the R naught will be affected by social interventions, so that where we see changes in the growth of the epidemic affected by, implementation of guidance and rules and regulations, it is going to affect the transmission rate, and it's going to be reflected in the R naught. So yeah, note the influence of public health interventions such as social distancing, masks, bans on gathering, etc. And just to show this, we just look at 2 studies which tried to estimate the R naught in different situations. One from Wuhan, China. This was in March of 2020, and it was estimated to be about 3.49. In other words, each person infected would transmit to, on average, about 3.49 other people. Singapore, which initially and still has brought in very, very strong public health measures and managed to contain the virus quite successfully, not at all. They managed to estimate that it was 0.6, so the pandemic was basically receding, disappearing in Singapore after containment. So you can see the main points again: changes over time. It will change according to factors such as new strains emerging, but also factors such as public health interventions, social behavior, and all of those factors. The other thing, okay, so that's R naught. It'll come back a little bit later when we talk about a few other things. Um, and the other epidemiological parameter that's often discussed is the case fatality ratio. In other words, what is the lethality of the virus? What is the how likely is someone to succumb to the virus? So there are two things. Again, fatality ratio is again dynamic, changes with time. It also changes depending upon how widespread the epidemic is. Actually, we will talk about that as well. If you look at the case fatality ratio, and I'm just going to define it in a second, you get a big range, depending on who you ask, depending on who's doing a study, where it's being done. You can imagine that the percentage of people who die, for example, of COVID-19 is partly going to depend upon what kind of health care they get. It's also going to depend on what the demography of the particular population is, what portion of the population is older, et cetera, et cetera. Who are the people being affected? Is it all young people? Is it all older people? Or is it a mix? So those issues, but let's just leave that for now and talk about a distinction that I want to make here between two fatality ratio parameters. One is infection fatality ratio and the other is case fatality ratio. So far I've been talking about the case fatality ratio, but what case fatality ratio means is that you have a confirmed case that is documented as being, in this case, COVID-19, and then you can have a confirmed report of the number of deaths from COVID-19, and that gives you a straightforward calculation of the proportion of people who or have confirmed cases and the proportion of people who died and attributed to COVID-19. So there's a number of different elements in there, including the fact that you have to have, that is not necessarily going to reflect the proportion of people who are actually infected, because of course they have to be documented to be infected and they have to be confirmed cases to calculate the case fatality ratio. The infection fatality ratio is the actual number of people infected out there in the population and the proportion of them that die. And that's a much more difficult number because we don't necessarily have an accurate data on how many people are infected, especially where you have so many people who are infected and are asymptomatic in the population. So you're going to have a very big difference between the IFR, the infection fatality rate, which is always estimated. It's usually, the number actually isn't usually available until much later in an epidemic, even after it's finished. You have to have some way of calculating how many people are actually infected. So there's that. So infection fatality ratio is going to give you a much smaller number than the case fatality ratio. Case fatality ratio is going to be confirmed cases and then looking at the proportion of those who die. So there are also some other issues in here about attribution of cause of death. One of the things we know is that there are differences in different jurisdictions in terms of the criteria for attributing a death to COVID-19. If someone dies of a stroke or myocardial infarction, or if they die of pneumonia, how efficiently is that attributed to the primary cause? If it's COVID-19 and it's not identified as such, it's an old person who dies, and depending on where they are, it's not reported as such, then of course we have a wrong attribution, and we have alteration of the CFR ultimately. One of the things about CFR is it changes over time. As you look at here, just this, don't worry about the complication of this, I'm not going to dwell on it. I was going to talk about the meta-analysis approach to calculating CFR, but I'm not going to. Just take this message that over the course, this shows months and this shows the CFR. The different lines, different colors represent different methods of calculation. It's a meta-analysis, so it's taken all kinds of many studies from many different places, pooled them together, done the statistics on them in different ways, in 4 different ways, and coming up with these very dynamic curves. You see that the numbers are changing as the epidemic has progressed. And this shows just days, this shows the actual date. But and when you look at this with respect to the number of people, you'll also see changes. So the more people who are infected, you'll notice that the CFR curves downward, and it was initially very high with when they were, I say initially, where there was relatively few cases, you had high CFR. So moving straight to pathophysiology and clinical, I just want to leave those epidemiological points behind now. Haven't covered coherently and comprehensively every aspect of epidemiology, I know, but just those points are going to link up, I think, to some of the pathophysiology and clinical things as well. So just some basics to make sure that you are clear on these points. Most people should be aware of them by now. Diagnosis, DX, it's still based on reverse transcriptase polymerase chain reaction, where you're basically getting a sample of tissue and then analyzing it for messenger RNA that has a specific sequence of nucleotides in it that is indicative of COVID-19. The false negative rate is very high for COVID-19 testing, depending on so many factors, depending on how long the person has been infected, depending on how much of a dose is actually in the nasopharynx where the swab is taken, or where, or in the mouth where a person can gargle. In some cases, you've got a lot of virus in there at the time they come in to get tested, and in other cases not. The person might actually be sick, but they may by that point not have as much virus available in their nasopharynx. I mean, these are all possible issues. But we know that, we're talking about something like, big range of false negatives. The quote used to be initially like 70%, 30% false positives, but it might be, other estimates of 70%, 67% false negatives. So, second point, quite different, is the clinical spectrum, of course. As we said, it's asymptomatic, can be very mild, moderate, or severe. The big point about asymptomatic people is, of course, that they're infectious, and this is why we have such a big epidemic now, really, because if you just had symptomatic people who are infectious, as we did with the previous SARS virus, much easier to identify people, quarantine, isolate them, and try to prevent further transmission. So it has to be differentially diagnosed from flu, of course, which is very common in the winter. Right now we're in the middle of winter. In Canada, there is usually lots of upper respiratory infections going around. By the way, less so this year, of course, because people are being so careful. But and then for moderate and severe cases, you've got, this is where you get into hospitalization and intensive therapy on the most intensive side, where people are really getting into critical care. It needs to be supported by ventilation support. Big recommendation now being for high flow oxygen cannulation instead of endotracheal intubation. Once you start getting into endotracheal intubation, you're talking about really last ditch effort to save someone's life, I think. Because intubation is actually, has been found now to be quite damaging. The lung injury that occurs with intubation in and of itself is quite significant. Not nearly the case with cannulation, of course. Yeah, and we'll talk about the drugs, but I've just listed the major categories here. There have been a number of trials that show both that using biologicals for immunomodulation can be helpful. And a lot of these are trials that are still ongoing, as well as plasma exchange, especially using convalescent plasma to. It's been found just recently, as of today. Nature, by the way, is convalescent plasma. In other words, plasma from a convalescent patient that is given to a person who is hospitalized. If it's given early, it can make a significant difference in survival rate. What we know about the transmission, of course, is that most people know by now that it's respiratory droplets, but we do have quite a bit of evidence that there are instances of aerosol transmission. Number of conferences, meetings, in restaurants, there's been a number of fairly well documented cases where a lot of people have been infected by one person in an interior space, especially if people are crowded together and talking, socializing, something like that. We would expect that with the number of people being infected in those instances, that it would be aerosol rather than respiratory droplets. So, as we said, transmissions by asymptomatic or anybody who's symptomatic, and also pre-symptomatic people. They haven't yet shown, but they're still infectious. Average time about 5 days from infection to manifestations. 97.5% develop symptoms by 11.5 days. So common symptoms, most common, fever, cough, shortness of breath, but also anosmia. Some studies have shown that over 90% of people lose their sense of smell. This is a bit controversial, but they're actually looking at this as possibly being a diagnostic criterion now because it's so widespread. But of course you have to carefully check. It's a symptom. You can't test for it objectively, so it's a symptom, not a sign. But on the signs for labs, lymphopenia, these are generalized signs, the LDH, and then of course the more specific one is the PCR, but its problem is high false negatives. So on the more serious side, where people become critical, about 5% of those infected and about 75% of those hospitalized are going to require oxygen support. As I said, most of it's going to be oxygen cannula, high flow oxygen cannulas. But the treatment for critical cases that are really getting into trouble is for acute respiratory distress syndrome, ARDS. And then I will mention about the corticosteroids, the primary one that's been shown to be effective at reducing death rate is dexamethasone. This is all from, we're seeing it all in Journal of the American Medical Association, JAMA. So just looking at pathophysiology. So if we start up here, this is from Anant Parashar in Postgraduate Medical Journal and published in Nature as well. So if you look at, this is a flow chart that highlights some of the main issues. You breathe in the aerosol or the respiratory droplet, and it, as the virus binds in the upper respiratory tract in the nasopharynx, and it binds to ACE2 proteins, which are receptors on a number of different tissues throughout the body, but are in high concentration actually around the substantial cells that support the nerve receptors, the olfactory receptors in the nasopharynx. This is suspected to be the reason that people lose their smell, is because those supporting cells, not the neurons themselves, it's been found, but at least the supporting cells are infected and maybe dying. But anyways, this ACE2 receptor is the key. I mean, it's the lock. It's the lock that is picked by the virus, it binds to it, and it's the spike 1 protein that binds to it. The spike is the part that sticks up that gives it its crown shape. Anyways, the viral spike protein changes its conformational shape, and you get penetration into the cell. And once it's into the cell, and it binds using clathrin-coated pits, it's endocytosed, taken up, starts to replicate, matures, synthesis of new virus. It's RNA. It's an RNA virus. It doesn't back transcribe, but that would be a retrovirus, but it reproduces in the cytoplasm. You get exocytosis after processing through the Golgi, and a new round of. There's another flowchart that we'll show here, a little bit more detailed. Again, binding of inhaled virus into the ciliated secretory cells of the navis epithelium to ACE2. The viral replication occurs in the nasopharynx. Colonization happens there, and it can. These are sort of the fate of what might happen. It can, at this point, be cleared from the patient. So most people will end up clearing in 10 to 14 days. Okay, it's about at least 80%. We said, asymptomatic cases are estimated at 93% in BC, but 80% overall is a pretty good number. And then about 20% end up that the virus is passed down, likely through droplets, into the respiratory tract and into the lower respiratory tract. And of course, the big entity that is going to result in a lot of cases is going to be pneumonia. So what we know is that type 2 alveolar cells will be invaded. These are phagocytic cells. We know that those are evident in the lungs, that there are these immune type cells and antigen presenting cells which are infected. They've got live virus in them. The cells are still alive, and that can result in release of particles and apoptosis, death of cells, and then the virus gets passed into other alveolar epitheliums, and that leads to the areas of damage that you typically see among the type 1 and type 2 pneumocytes. You end up with the ground glass opacity that you see on imaging, which is diffuse alveolar damage across the lung field. And at this point, the person is into acute respiratory distress syndrome and into severe situation. The other thing that happens that's difficult to deal with is, of course, the macrophages harboring all of this virus and being infected and taking it up triggers inflammation and triggers it through all the signals that have been found to be released here. And as this goes on, it can really lead to an out-of-control inflammatory response known as the cytokine storm, or you can think of it as an inflammatory storm. And as this happens, it causes a lot of activation. It's sort of an over-exuberant immune response. It leads to massive inflammation, exudation, flooding of the lungs, and this is where people really benefit from the steroids to dampen the inflammatory response. So this just gives a breakdown. That's paper from Wu. This was fairly early on, but late enough that it gave, it was 72,000 cases in China that were reported on here. It just gives an idea of what the breakdown is. In this study, as I said, about 81% are mild or moderate, and then another 14% severe, and then critical, as I showed in the picture, about 5% with respiratory failure. Septic shock, okay, there's an issue there of people getting super infections during this situation, and multiple organ dysfunction syndrome, and that of course is we're talking about end stage, and we're talking about septic shock, respiratory failure, and MODS. These are critical patients. And as I mentioned, diffuse alveolar damage across the lung field, and it looks upon imaging like ground glass, and that's one of the very common signs for these critical patients. The labs I mentioned, leukopenia, lymphopenia, enzymes, and also C-reactive protein. So just a breakdown of this is from another paper of clinical manifestations. About 70% fever, cough, and dyspnea, 36% with myalgia, 34% headache. These are very common ones. But also, as I said, diarrhea, dizziness, rhinorrhea, anosmia, which is, as I talked about, dysgeusia, which is bad taste in the mouth, which can last for a long time even after the infection has gone away, and others as well. Okay, so when you look at overall clinical manifestations, I know it's a quick tour, but just to give you an idea of the picture and just to consolidate with more recent findings, if you look at what's been found, initially, and everybody focuses on the respiratory part of this as I just did now, but we know that if you look at the totality of patients that are affected, that the manifestations are felt across a number of systems. The cardiac part of it is now known to be very important, partly because in the vasculature, the endothelial cells, as well as heart cells, have an ACE2 receptor in high concentrations, but also there's dermatological, the hematological system, the liver, neurological, and the kidneys is particularly important. For critically ill patients, there's a very high risk of venous thromboembolus. In other words, thromboemboli that are occurring that either DVT is included in that, and also, of course, PE, pulmonary embolism, as a result. As you remember, pulmonary embolism is going to be one of the really high risk situations as a result of activation of fibrinogenesis and formation of a thromboembolus that moves through the system towards the lungs. So if we just look at finishing this off, just considering a couple of things. One is, the major areas, and I leave this to your clinical instructors to give you all the specifics of protocols, but just to list some of the key areas. I think you've got it probably by now. Number one is, of course, infection control protocols that have to be followed, and by now you know quite a bit of them, but certainly different centers are going to be using somewhat different protocols, I believe. But pay attention to hemodynamics of the patient, to oxygen and ventilation, obviously, AKI and renal replacement therapy, and then the drugs and extracorporeal membrane oxygenation, possibly in some centers. These are, to address hypoxia, of course. Okay, just on the issue of drugs, I wanted to update exactly, spend a fair amount of time going through and trying to find all the latest and greatest on what our best guidance is for drug use for critical patients. So what I ended up doing, of course, is going to the main authorities, which is in British Columbia, the BC Centre for Disease Control, and found that those recommendations are, taken from Public Health Agency Canada, but they're also consistent with WHO, World Health Organization, and the Canadian Critical Care Society. So if you look at these, so you've got a fair bit of agreement on this. Recommended drugs, the one that's been found to be significant benefit in terms of reducing mortality is dexamethasone, or if dexamethasone is in short supply, other corticosteroids, hydroxycortisone or methylprednisone. Antibiotics, if there's bacterial infections, acetaminophen. They're not recommending NSAIDs, by the way, like ibuprofen, but it's still being assessed. ACE inhibitors only if the person is already on them, and anticoagulants like enoxaparin, okay, especially for critically ill patients because of the risk of VTE, as I mentioned. Okay, for the conditional or approved in, sorry, traditional or in approved randomized control trials. So these are things that are not quite yet assessed. You've got different things, including um, antivirals, so remdesivir and lopinavir. Remdesivir had early promise, but now they've sort of backed off in recommending it. It's still in trials. And then a number of biologicals. These are immunomodulators. Like I just saw a paper on this one today. It did have some beneficial effects in the study. But anyways, these drugs are still being assessed. You may find they're being used, but they would be part of a trial, as I said. And even convalescent plasma, which you hear a lot about, but it's still not recommended in British Columbia or Canada, unless it's in trial. Monoclonal antibodies, SSRIs, conditionally, and then not recommended. I mean, goes back to some of the red herrings that were thrown out there, including the big one, which was chloroquine, which was crazily promoted by the American government, even the president, Trump. I mean, without knowing anything, just, I guess, hope or something. I don't know. Chloroquine, which is the anti-malarial, turned out to have some hazards. In fact, putting people at risk for cardiovascular events, and a number of others which have been found to be harmful. And I put a bunch of things. I mean, it's a big list of things that have been published. Something has been published about them, anyways, that have been found to be verboten. So immunity in RNA viruses. I want to just quickly give a quick review of the immune defenses that have been found here. It's consistent with everything you know about immunity already. And then we'll talk about the RNA vaccines and how they work and what they mean. If you look at this picture, it just shows you a scheme. It shows you the viral infection going on in the first part of the picture, and here's the detailed picture of the virus with its different antigens. You can see the spike protein very prominent there, which is the main thing, which is going to be antigenic in the vaccines, as I said. But the proteins have been identified in the viral coat that are especially important. You can see a detailed picture showing that as it binds to the ACE2 receptor in the host cell, it is also requires this furin protein activation to actually internalize. So the virus is uptaken into the host cell. It releases this RNA, which then translates into the viral proteins assembly, uptake into a vesicle for exocytosis, then release into the environment to be transmitted somewhere else. Now, what should happen in terms of the immune response, of course, is that the virus is detected and uptaken into dendritic cells and other APCs, antigen-presenting cells, which then present the digested antigens. So, for example, the spike protein will be digested in proteasomes, presented to the T helper cell, this CD4 cell, which then is going to activate CD8 cells, the cytotoxic T cell, as well as B cells, which are then going to mature into plasma cells and produce antibodies against the antigens that have been presented down here. And along the way, you also have the production of memory B cells and memory T cells. So this is where lasting immunity occurs. Now, by the way, I can add one other additional piece of information that just came out as of yesterday in a paper, that it turns out that people who are infected have effective, long-lasting immunity, which has been a question that people have been wondering about. So, at least in this particular study, it showed this fairly conclusively. So people who have been infected, depending on how severe the infection is, they're going to have some degree of immunological memory months later at least, and perhaps hopefully longer than that. Okay, so vaccines, of course, are ways of manipulating the immune system to prompt an immune response with memory. And there are different approaches being taken right now. The classic ones are the first two. Well, the most classic one is protein-based, the first number one issue, which is essentially taking the spike protein, purifying it, injecting it into the person to promote, to get their immune system to react and produce antibody and memory. But the second thing that has been used for a number of years, though, is to use a viral carrier to more efficiently get the viral. So when we say a viral carrier, I'm saying that it's a carrier of the genes of the virus in question, the SARS-CoV-2 virus in this case. So in other words, we take the RNA, we package it into an adenovirus, which is a relatively harmless virus, and then that virus, once it gets into your tissue, translates it into spike protein or antigenic protein, and that stimulates the immune response to get memory and antibodies. But the new thing, of course, and this is the first time that this strategy has been used, is that messenger RNA from the virus is identified, purified, synthesized, and then packaged into a liposome, which is not shown here. It's a synthetic membrane, which then infects and, is inoculated and is injected into the person. I shouldn't use the word infects here, but the liposome passes the mRNA into the host cells, like dendritic cells, which then end up translating the protein, making the protein, which is then digested, in fact, and is presented to the immune system to generate the immunity, the antibodies, and the memory cells. So mRNA vaccines, so you've all heard it being called that. This is, what you should know is, this is a brand new technology. Everybody's watching it carefully. It seems to be very successful. A huge advantage of it is that the mRNA is synthesized, it can be designed easily, it can be adjusted easily, and the vaccine can be produced very fast. It's the packaging into liposomes has been worked out here in Vancouver, by the way, by Dr. Tom Madden's company, and that's a big part of this. It's just often not mentioned in the media and stuff. But so the Pfizer and Moderna mRNA vaccines, just this is a picture just showing what I just said, but it shows it in a little bit more detail, that the mRNA vaccine is, in the liposome, the double bilayer, the bilayer, it's synthetic. It integrates with the membrane, passes the mRNA in. The mRNA triggers translation to the proteins, the spike proteins. In fact, they get digested by proteasomes, and then the pieces of antigen end up being presented to the surface and being presented to the immune system and prompting the immune response. So we're talking about, in both those cases, we're talking about vaccines that seem to be 90% plus effective, which is very, very impressive, and everyone was very, very surprised to see it. This is just I'm just, same thing I've just said. I just laid it out in a slide here in words for those people who want to just think about this and look at it in words instead of pictures. Okay, so I just put that there for you. I do want students to understand how these vaccines differ from traditional vaccines, and to be aware that it's a new technology that is probably a huge breakthrough in vaccine development. Because what it means is that not only for emerging viruses and new viruses can you come up with a vaccine very quickly, but there's another whole aspect to this. Is I think very soon we're going to see these RNA vaccines being designed against tumors, So it might represent a cancer treatment. That's always been one of the goals of people developing these RNA vaccines. And then I'm speculating that it's possible that they may even get to the point where RNA vaccines are customized to individual cancer patients to address their individual tumors. The last topic here, I know I've gone a little bit long, but just to finish up, the strains that are emerging. It's a big question. Just I want you to understand a little bit about this, that new mutations are happening all the time, of course. They lead to new variants. This has been, being documented all the time with genomic analysis of SARS-CoV-2, so we know that it's going on. And in many places in the world, they're documenting the genomes of the new variants quite carefully. But if there are a lot of the variants are going to be variants that are deleterious to the virus, that they're not going to help the virus at all. Once in a while, though, just by chance, you can have variants that are eventually going to come up, which are going to increase efficiency of transmission, and that seems to be what's the case right now. So once this happens, the new variants are going to be what's going to be the normal new variant, the normal new virus, and that's going to, of course, be subject to more mutations. So if you look at the first significant one that was recognized a few weeks ago, it's, by the way, the naming of it is still controversial. They just had a big meeting at the WHO about naming because it's just a big mess naming these things. But let's just call it the UK variant, even though it's got political problems to say that. But it was noticed because there was a huge surge in cases in Kent, England. People did genetic analysis. They found the strain was different in about 32 different places on the genome. And then more recently, what's been found is that when they tested to find out what the transmissibility was, they found that the R naught was about 50 to 70% higher than previous virus. So the strain is significantly more transmissible, which means that it will take over as the new virus, and it'll become the dominant strain. And as that happens, it's going to set the stage for further mutations one way or another. So it's a very concerning situation, let's put it that way. There's no evidence that it's more lethal, but we know that if you have higher transmission infectivity, you'll have more cases, more hospitalizations, more critical cases, and more deaths, no doubt. So race is on between the vaccines and getting the vaccines out there and the appearance of these new strains. So this started just a few weeks ago. Now we're looking at strains that are emerged in South Africa, Japan, Brazil, and this is something about the other mutations. They're full of questions. We don't know yet what the situation is going to end up in. But just lastly, if you look at a site like NextStrain, which is fascinating, it gives you an idea of the whole phylogenetics of COVID-19 that's been tracked. And this looks at date on the x-axis. This is from NextGen. You can click on this and go there. Fascinating site to go to. It shows you the phylogeny, and you can see the different colors represent different strains that have emerged. You can even look at them in different places. So this is a map showing different strains that have been labeled based on their mutations, and you can see that in different places you have different mixes of different strains. So this is being changed. This is a dynamic sort of website showing you the changes that are going on all the time. You can track the changes that are occurring as these new strains occur. So that wraps it up. And I hope this helps with everything, with your understanding, and answers some of your questions and clarifies